Okay, so we're finished with infection control and we're going to talk about safety now. I want to call your attention to your textbook. We're going to start on page 552. We're really going to concentrate on safety in the healthcare setting. Chapter 24 kind of goes far and wide. It's air pollution, it's suffocation, choking hazards, car seat safety, firearms, drowning, a lot of things that happen out there in the community or at home. For your purposes, what's most important to focus on is safety in the healthcare setting. So we're going to start on page 552, and we can move from there. And I want to pull a few pieces of information out of your book. On page 552, it mentions that as many, and I think this is sort of an outdated number, as many as 98,000 people die from medical injuries each year in U.S. hospitals. I've seen numbers that go upward of 144,000. People each year, and that does not reflect people who are injured in the hospital. There are people who suffer serious harm in the hospital that don't die every year, and we don't really have good numbers on those. We do know from the AHRQ is that about 700,000, and this is why I want to concentrate on this, to 1 million patients in the hospital every year suffer falls. And so we are going to spend a pretty good amount of time on preventing falls. Anyway, the key to safety in the hospital is really through your nursing care. So good nursing practice will prevent many incidents. It's a key thing to risk reduction. You can have a brilliant medical team, a surgeon who can very skillfully perform a delicate operation. You can have, all kinds of things going for you. If you don't have good nursing care in the hospital, your patients do not do well. They suffer. If you have good nurses but not enough of them, patients will suffer. So remember that good nursing practice prevents a lot of risk to patients. Okay, so let's talk again about those never events. We talked about the ones related to infection, but we didn't talk about some of the other ones. So your book has this list on page 553 if you want to refer to it. Foreign objects left in a patient. This is a never event. And this is why when you do your perioperative experience, and maybe if you go to OB and see a C-section, you're going to see a lot of counting. It's very tedious, but you do it because you know you have to keep that patient safe, and you have to be very vigilant while you do it. You count sponges, you count instruments, you count sharps. Anything that could be left in a patient, anything that could fall into a patient gets counted. And if the counts are not correct, everyone stops. Well, the surgeon doesn't stop, but the nurse and the scrub will stop, and they will hunt and look for that object. I have spent a lot of time looking for sponges that ended up being under the surgeon's foot. Just saying, but you do it because you know that a foreign object left behind in a patient causes untold misery, infection, and pain. And so we don't want that to happen. It's something that should never happen. Air embolism. Very rare. It takes a lot of air to actually become an embolus, mostly because nitrogen dissolves so readily in the blood. But, it should never happen, obviously. You should never be putting a whole tubing full of air. You should prime your lines and do things to prevent harm. Administering the wrong blood to a patient. Big one. And this usually happens because either somebody wasn't paying attention when they checked, or the wrong type and cross went down to the blood bank and they released a unit of blood they thought matched your patient when really it was someone else's blood. But this is something, when you learn how to do blood transfusions in January of this year or next year, you're going to learn how many checks and what you look for. But that is something that should never happen. These are all never events. Severe pressure ulcers. Now, obviously, you can't prevent every blister or redness or little bit of redness, but you can prevent the ones that go to stage 2 or stage 3, stage 4, and ones that become unstageable by simple skincare measures. There's a lot of things you can do to prevent those things. You'll learn about most of them when you learn about the integument with Mrs. Montefar. Another never event, falls and trauma. We do not want people to fall in the hospital. As I said, 700,000 to 1 million people fall in the hospital every year, and Joint Commission says it's a never event. Well, 700,000 is not never. So we have a long way to go before this is a reality. And in honesty, I don't know that it's realistic that nobody will ever fall in a hospital, but we can certainly do better preventing harm to patients, trauma to patients too. Just people who, get skin tears from being handled inappropriately or suffer injury for other things. And then we have a big category, and we'll probably go into this a little bit. Injuries, burns, restraints, or bed rails. Big ones. These are never events, but people do get burned sometimes in the hospital. How does that happen? Well, somebody makes a heating pad trying to comfort the patient, doesn't test the temperature, and maybe you have a patient who either can't tell you that it hurts, or they have nerve damage that they can't feel it. They've got neuropathy in their feet and you're putting a hot pack on them. Restraints. Restraints can be very, very, very dangerous. People can strangle in restraints. They can get entangled in bed rails. They can tip chairs over if they've got, if they're in a chair restraint or a vest restraint in a wheelchair. In bed rails, people get trapped in bed rails all the time, so be very wary of putting all 4 side rails up. It's considered a restraint. Most places are restraint-free, but we don't want to harm people from the interventions that we do. You're not trying to hurt somebody when you give them a heating pad, but you can, and so that's considered a never event. And then we have a couple of infections, the CAUTIs, the urinary catheter infections, which we'll talk about when we talk about inserting Foley's, how to prevent those. And we talk a little bit about that, I think, in elimination. If not, call me on it and we'll talk about it in class. Infections associated with IV catheters, again, should never happen. Symptoms resulting from poorly controlled blood sugars, and I have a good story about that, but I'll save it for class. Just remind me. We should be checking our patients' blood sugars and communicating with providers if they're not in range and treating them. There are usually pretty good protocols in place when your patient's blood sugar is low. I know at our hospital at St. Francis, there's a whole protocol, and it starts with oral, maybe we give a little sugar orally. If the patient can't swallow or if they're unconscious, then we give them other stuff, but we'll talk about that later when we do glucometers. Probably in clinical. Surgical site infections, we talked about those, and deep vein thrombosis or pulmonary embolus after a total knee or hip replacement procedure. We should risk people out and we should get them up and moving, but I'm not going to talk about them in terms of this discussion. Okay, so those are your never events. Your book also mentions a term called root cause analysis. When you have what's called a sentinel event, something happens in your hospital that should never happen anywhere. It makes everybody pay attention and say, what could happen here? And a root cause analysis is part of that culture of safety. We don't blame the person who made the error necessarily. We look for the root cause. How did this person who had good intentions and was trained and passed their NCLEX and had an orientation, how did this person make this mistake? What was it about our healthcare culture that allowed it to happen? Because really there should be lots of different points where errors can be prevented. Now, I promised that we would have a special emphasis on falls. Hold on, let me get rid of stuff we just had. And we'll put this up. So falls are a big thing. We're going to kind of go through the nursing process with this as our prototype. So let's start with assessment. You're going to get a thorough history from the patient because the number one risk factor for falls is a previous fall. We also want to know what medications the person is taking. For example, a patient who's on narcotic pain medication is a little less steady and more likely to fall. Those people who are on sleep meds, remember we talked about them in sleep and rest. People who are on anti-anxiety medication, especially your elderly folks. And also we can talk about antihypertensives. Antihypertensives are medications that lower your blood pressure. If they lower your blood pressure too much, you get dizzy when you stand up and you fall. Now, something else that you'll want to assess is any history of chronic disease. And I'm going to put a spotlight on diabetes because diabetes leads to peripheral neuropathy. And that can make people not be able to really sense the floor on their feet. So any unevenness, and you'll start to see people walk really differently when they have neuropathy. Their feet just feel like they're not touching the floor all the way. And so they're never really sure where they stand literally. And those people are more likely to fall. Okay, so we're going to talk about an assessment tool called the Morse Falls Risk. It's in your DocuCare. So when you assess your patients in clinical, I'm going to be looking to see if you do a Morse Fall scale. Okay, so here it is. Again, it's on page 557 if you need that written reference, and that's okay. Does the patient have a history of falling? And that, I said, was the #1 risk factor. Does the patient have more than one medical diagnosis? That's going to lead to more medications, more interactions between medication, and also more chronic conditions that can impact the person's falls risk. Does the patient use assistive devices such as canes, walkers, crutches? Increases the risk of falling. Does the person have an IV line or a saline lock? Now, saline lock, it's kind of hard for me to imagine that being a risk for falls, but it is on the Morse Falls risk. And running IV, yes, because you have now a pole that's on wheels and you have tubing, and people sometimes fall and trip. I've seen people use their IV poles as like a walker almost, and you're like, oh no, this lady's gonna face plant, or this gentleman's like headed for the floor. So you really want to educate your patient not to use their IV pole as a walking assistive device. And then you're going to look at gait. Remember, in mobility and physical activity, I said don't worry about antalgic or scissors or spastic or waddling. Worry about steady or not steady. When you look at a person, do they look like they're wobbling? Do they look like they can walk in a straight line and they're fine, or do they look like they're very wobbly and maybe they're lurching a little bit? If their gait is stooped or anything abnormal, you're going to notice it, and that does increase that person's risk. And then you're going to look at mental status. People who are confused are much more likely to fall for obvious reasons. If they're disoriented and forgetful, they might forget to call you. They might forget that they can't reach the bathroom by themselves. They might forget that they've fallen. They might forget where stuff is. And in the middle of the night, sometimes elderly people with Alzheimer's disease tend to sundown. They get agitated, and that's when they start walking around, and their other issues make them likely to fall. So that's your Morse Falls risk. In DocuCare, you're going to see it. It will give you a number, and it will tell you at what risk your patient is at. And you might see it also in Sorian. I think that's the tool they use as well. So we'll play with that a little bit in clinical. You're not allowed to document when we get to clinical, but you are allowed to read patient records, and that's going to be an important way that you learn. There are some other tests, and I had the class last year do Get Up and Go. And this was, you ask the patient about falls. If they report a single fall, you do this Get Up and Go test. And it's kind of interesting. You get people to stand up and they have to walk around a chair and come back, and you watch them and you time them and see how long it takes them to go, and you kind of make sure that they're not lurching all over the place. So it's, and there is a time limit on it. We can play with it in class if you want to. But that is a good test to decide whether or not somebody is at higher risk for falls. And then, of course, you're going to assess the environment. Is it free of clutter, spills? Is there a path to the bathroom? And then you're going to want to make sure that the room is well lit. Now I know we said a dark room is best for sleeping, and I think I remember saying dark but not pitch black. Because patients who get up, they're not in a familiar environment, they may be a little disoriented, they may be medicated. If it's pitch black, they're not going to see what's in front of them, they're going to trip over it and they're going to fall. So we don't want that to happen. Now I'd like to talk to you a little bit about side rails. People think I put the side rails up ×2. That's a good start. You don't want all 4 of them up. But don't be fooled into thinking that's really going to protect your patient. You need to be very vigilant when your patient's at risk. Sorry. Just want to type that all out. You can stop it now and take a note because I'm going to move on, but you can take a screenshot. Okay, so our main diagnosis for falling, a person who's at risk for falling is a risk for falls. Goal or outcome is patient will remain free of falls throughout admission. And that's pretty straightforward. It's just like risk for infection, and our goal is obviously if they're not going to have an infection. You really don't need an as evidenced by statement, but you should have a related to statement under risk for falls. For example, risk for falls related to impaired balance or altered mental status or altered sensory people who have visual deficits or whatever. Your related to factors your cause, and that's going to be part of your implementation. So now let's start talking about interventions that we can do for people who are at risk for falls. And one of them is going to be assess that patient frequently and find out if they need help ambulating to the bathroom. Another thing we're going to do is identify the patient at risk so that everybody knows that this patient is at risk for falling and they don't let them ambulate by themselves or leave any hazardous stuff around. And one of the ways that we do that, some hospitals use yellow slipper socks. A lot of them have a door card or with a little falling star. You're going to report it. You'll hear this a lot when you're at St. Francis. So-and-so, 39 years old, falling star, means he's at risk for falls. So with every shift change, every time you transfer that patient, hand them off to somebody, say he's a falling star, and that door card will have the falling star on it. Some places use yellow bracelets to denote that patient is free of, is a falls risk. So there's that. And then we do patient teaching. Unless your patient's mental status is very, very altered, we do patient teaching to say, ask for assistance. With OOBs out of bed, by the way. Now, for the patient who's at risk for falls because they have altered mental status and they keep getting up and there's nothing you can do with teaching, we have interventions like bed alarms. And these are a good alternative to restraints because restraints can also cause injury to patients, and that's sort of a topic I'm going to touch on next. But a bed alarm kind of clips onto the back of the bed or the chair, and when the patient gets out of the bed, it alarms the nursing staff, alerts the nursing staff to come and rescue that patient before they fall. So that is another safety thing that we can do. We want to make sure that we're medicating our patients appropriately and carefully and thoughtfully. If we have patients who are elderly that don't metabolize their medications well, we're going to be very, very careful to make sure that we don't over-medicate them and make sure that we don't create interactions between multiple drugs. And we're going to watch all of those medications that cause the falls risk to be higher. For example, those pain medications, sleep medications, some of your psych meds, and certainly anything sedating, and then anything that lowers your blood pressure. So we're going to medicate carefully, and we're going to evaluate the patient's response and adjust. Let the provider know how that patient responds, so that they can adjust the routine if they have to. So those are all things that we can do for the patient who is at risk for falls. Now, there are other things that can happen to patients in the hospital. We're going to talk about a few of them. We're going to talk about them kind of faster. but they can be injured by equipment that isn't functioning properly. For example, if we set certain machines inappropriately, we have a machine in the or device in the OR called a Bovie, and what it does is it uses heat to cauterize small blood vessels so the patient doesn't bleed. If we don't put a grounding pad on that patient and we don't ground that device, we can cause electrical injury to that patient. Obviously, if the alarms on certain equipment, you have ventilators that don't alarm properly or the settings are not adjusted correctly, that can cause harm to the patient. So we always want to be careful with our equipment. And as you learn different skills and different aspects of patient care, every time we talk about them, we'll be bringing up the safety aspects because it is such an important thing that you do. We can also talk a little bit about burns and trauma. They should never happen to a patient, but sometimes very well-meaning nurses will try to help a patient by putting a warm pack on their skin. And elderly patients who have very thin skin that is prone to injury can be very seriously damaged. Newborns with very fragile skin, we like to warm their foot to get a blood sample from the heel. Most hospitals, both of the ones that I've worked at in maternity, had chemical heat packs that you could kind of break the little capsule and then it warmed up to a very specific temperature. Those are the things that we use in the hospital because people used to use things like diapers with hot water or washcloths soaked in hot water, and babies have such thin skin that just a few degrees can make the difference between scalding and intact healthy skin. And obviously trauma, if you're moving a patient and that patient is damaged, maybe they're on a stretcher or something like that and you bump them a little hard and they get bruised, we don't want that. So you're always going to handle your patients as safely as you can and do anything to avoid trauma. For example, skin tears used to be very common. I worked in one long-term care facility where they had a whole team of people who worked on skin tears because when patients were moved up in bed or when they were turned to their side, sometimes the unlicensed assistive personnel was not as careful as they could have been, and they caused what's called a shearing force, which is when the skin is dragged against the sheet, and that trauma, when your skin is paper thin, just rips it right open, and it really does look pretty bad. We had talked about pressure ulcers. You're going to talk about them more in integument, so I'm not going to labor them to death. Let's go on to restraints, though. And I know there was a lab on restraints and there was ATI on restraints, and you've heard a lot about restraints, but we're going to talk about some of the injuries that can happen with restraints. Patients who are in a vest restraint who try to get out of it, and they are like little wiggle worms, sometimes those patients with very altered mental status, they would get the vest around their neck and they would strangle themselves in it. People have gotten entrapped in bed rails trying to get out of them, and they can die from that. People, especially when you have all four of them up, they feel like they're in jail, they get a little bit delusional, and they try to escape, and they get trapped between the mattress and the side rail, so that's unsafe. People can get injured by a wrist restraint that's applied too tightly. People can get contractures. Remember, activity and mobility, when you don't move a joint through its full range of motion. If we're not doing range of motion, if we're not doing those skin checks, if we're not checking on that patient every hour, if we're not monitoring appropriately, restraints can be very dangerous. And that's why most places now are restraint free. You have to have a really clear indication to apply restraints. Sometimes they're necessary, but most of the time there are things we can do like bed alarms or a one-to-one or even distraction, use of family members to do that. Much better alternatives to restraints in most cases. So when we know that the patient is at risk for injury, obviously a nursing diagnosis is going to be risk for injury. And it might be related to surgical procedure. It might be related to any number of things that puts that patient at risk for injury. And so we're going to do all kinds of things to prevent it. And like I said, avoid restraints. Make sure your equipment functions appropriately. You should check it every shift. Make sure your suction, your oxygen, patient's ventilated. You should be checking that machine, making sure all alarms are set to within the agency protocol. Obviously, when you do blood, you're going to learn about that as a separate skill. but you're going to check and make sure that you've ID'd your patient correctly. Make sure, that when you give medications that you've ID'd your patient. And you will get a lot more about medication administration in just a few weeks, so I'm not going to linger on that. But when you have risk for injury, obviously you're going to put precautions into place. And because there's more than one thing that can go wrong, I'm not going to list them per se. I want you to really think about falls prevention and general safety kinds of things. And always, as we progress in clinical, we'll be pointing out things to you that maybe indicate a risk for injury to your patient, or a risk for falls, or risk for infection. And so I think that's about right. Now, when we want to assess, was our care successful? Was patient free from injury or falls? If nothing bad happened to these people, then your intervention was successful. If something did, you're going to fill out an incident report, or I think now the more popular term in both places I work is a safety report. There's usually an electronic way of doing that. It's not part of the patient's record. It goes to risk management, and they'll analyze that incident and see what was it that went wrong. Was it just a lapse of judgment on your part, or was it poor staffing? And they usually don't come up with that conclusion. But was there a systems, a policy that could be changed that would prevent this error? And so that's how we evaluate our care, and that's it for safety.